Welcome to the 2020 Georgia Legislative Policy Forum. I'm Kyle Wingfield. I'm the President and CEO of the Georgia Public Policy Foundation. We're very glad you joined us today. This is the final week of our series, but not the final event. For 7 weeks now, we have been exploring issues that affect Georgians in keeping with this year's theme, Wisdom, Justice, Adaptation. If you missed the earlier events, including our opening keynote with U.S. Secretary of Education Betsy DeVos, and panel discussions about education, the budget, land use and transportation, the economy, and housing, you can find recordings on our YouTube channel, Georgia Policy. After today's event, we'll be back here this Thursday, just 2 days from now, at 11 a.m. for our closing keynote speaker, Chief Justice Harold Melton of the Georgia Supreme Court. With so much changing in the world around us, he'll be speaking about what remains constant in our constitutional order. It'll be a great way to wrap up this series. Again, please note that this session will not follow the regular schedule and that Chief Justice Melton will join us this Thursday, August 27th. You can register for that session on our website, georgiapolicy.org/events. Now, we are also grateful for the support of some key sponsors in this series. And they are our presenting sponsor, AT&T, our platinum sponsors, Verizon and the Walton Family Foundation, and our silver sponsor, the Georgia Association of Realtors. We thank each of them for their support of this event, which has allowed us to offer this outstanding lineup of speakers at no cost to our audience. We would, however, appreciate your voluntary support of our work, and you can visit georgiapolicy.org/donate to make a tax-deductible contribution. During this morning's program, we would like to hear questions from you in the audience. You can submit those in the chat or Q&A boxes on your screen. Just type your question there and we'll try to get to as many as we can in the time we have. We have a great panel lined up to discuss healthcare, but first we have the pleasure of hearing about recent developments in state healthcare policy from State Representative Matt Hatchett. He's the Vice Chairman of the House Rules Committee and Chairman of the House Republican Caucus. So Chairman Hatchett, what have you and your colleagues been up to regarding healthcare policy?
Thanks, Cal. Thanks for, can you hear me okay?
Yes, okay. Go ahead.
Thanks for allowing me to be on. I'm not sure that I'm near the caliber of Betsy DeVos or Chief Justice Harold Melton, but thanks for having me on. You know, the last 2 years have been busy years for healthcare legislation. We passed a lot of legislation in 2019 that involved CON and other updates to our healthcare system. And then that was followed this year by quite a few bills. And I thought I would just, you discuss and highlight some of the bills that we did pass. And I'll start with House Bill 1114 by Chairwoman Sharon Cooper. That bill lengthened the time of Medicaid coverage for new moms from 2 months to 6 months after birth. And I really think this will help us in reducing our issue with maternal mortality and infant mortality, hopefully reducing those rates because we have a lot of room to go there. Chairwoman Cooper also championed House Bill 987, which put in place new requirements for training and reporting for the assisted living industry. That industry worked with the committee to bring new oversights and training and established a state board of long-term care facility administration to help enforce the requirements in that industry. Chairman Lee Hawkins championed the all-encompassing House Bill 888 to address the issue of surprise billing. That bill has been discussed, I think, for 6 years, and many years of trial and tribulation, and finally was brought across the finish line. It covers all aspects of payment, arbitration for all the services that are usually provided in hospitals that the patient may or may not know about when the services are provided. House Bill 789 by Chairman Mark Newton was a sister bill to that and placing a rating system on hospitals that highlight the hospital-based specialty groups and their in-network statuses. In an effort to bring to help younger women receive earlier care for possible breast cancer. Majority Whip Trey Kelly passed legislation that requires the state health benefit plan to include breast cancer screenings beginning at the age of 30 for women who are at higher risk of breast cancer. And to show a little balance and talk about a Senate bill, I'm going to talk about SB 482 that Senator Dean Burke passed, and it establishes an all-payer claims database that will allow the state to monitor cost, and more importantly, it's going to help monitor health outcomes and address problems that we may see across the state regionally and direct resources to those places where these health issues may be, and we can hopefully improve the health of these areas. And finally, I'd be remiss if I didn't mention the broad strokes of change passed in several bills concerning PBMs. One bill, House Bill 918, addressed the frequency, number of prescriptions, and penalties determined in audits of pharmacists. This will hopefully limit the undue harassment of our hardworking pharmacists. House Bill 946, which Chairman David Knight championed, sets the reimbursement cost for drugs using the national average drug acquisition cost as the benchmark. PBMs will also have to pass on to any health plan the 100% of any rebates received. 946 also clarified the abolishment of the abuse of spread pricing and steering by PBMs. HB 946 overall and in summary tried to place our independent pharmacists on a level and equal footing, a level playing ground with the big box pharmacies that are owned by some of the PBMs and bigger companies, and trying to equal the day-to-day reimbursements and the day-to-day operations. And then finally, HB 991 by me, which established an oversight committee for all contractors and subcontractors under the Department of Health, and it was vetoed. It will be revisited. HB 991, it would simply have brought further transparency to the industry that accounts for more than $4 billion in expenditures in our state budget, and further adds to the hospital transparency bill from last year that is bringing transparency to our nonprofit hospital industry. We also passed legislation that did some loosening of scope of practice for APRNs, help them, allow them to order routine diagnostic tests like MRIs in non-life-threatening situations, and update with the physician assistants where up to 4 can be supervised by a doctor, up from 2. I'm sure that next year we'll have some more scope of practice reform, as we always have that, seems like every year. And we'll have, of course, some more looks at and updates and reforms to CON, Certificate of Need, which it's near and dear to my heart. And that's all I really got for now. There were other bills, but I talk about them, it'll put everybody watching asleep, and we'll start losing them left and right. So thank you, Kyle.
That was great, and definitely gives us some context for what's happening in Georgia on this issue as we go forward. For those in the audience, Chairman Hatchett will be rejoining us after the panel discussion for the Q&A portion. So please submit any questions you have for him, along with the panelists, in the chat and Q&A boxes. Let me remind everyone that the program for all of our panelists' full bios can be found on our homepage, georgiapolicy.org. And with that, I'll turn things over to our moderator, Marie Fishpaw, who is the Director of Domestic Policy Studies at the Heritage Foundation. Marie, thanks for being with us today, and the floor is yours.
Well, good morning, and thank you, Kyle. We have quite a series of questions to answer, and quite a distinguished panel to help answer that. One thing the COVID-19 pandemic has exposed is some really major opportunities to reform how our healthcare system works and make it work better for patients and doctors. Many of these problems have been around for a while, and so we're going to focus today on the lessons that we're seeing about how to address these longstanding problems. So we have Marilyn Bartlett, who is a Senior Policy Fellow from the National Academy for State Health Policy. We have Brian Blase, who is the founder and president of Blase Strategies. We have Avik Roy, also co-founder and president of a think tank called the Foundation for Research on Equal Opportunity. And with that, we're going to go straight to Avik. Avik, adaptation has been the key word when we think about pandemic and how people have had to respond quickly. Whether it's policymakers, doctors, patients, our daily lives have all been changed, and we've been asked to do a lot. You've spent a lot of time thinking about how policymakers might adjust their response to the pandemic. So if there was one thing that policymakers could do to adjust how they are responding to the pandemic, what would that be, and how would that help us address some of the long-standing problems that have been around for a while in our system? Avik?
Well, hi, Maria, and hi, everybody. It's very hard to come up with one because this pandemic has exposed a long litany, and we've written a lot about that litany of problems. Let me try to highlight a few. First, at the state level in particular, we've had terrible data reporting. You need real-time data that's accurate and tells you what's actually going on. So for example, if you're a governor and you don't know whether someone died of COVID or just happened to test positive and died in a motorcycle accident, how are you going to know whether or not there's been an outbreak, whether there's been a serious rise in the epidemic? Same thing with hospitalizations, same thing with testing. So the data reporting piece has been a huge problem. Another place where that's played out is in the nursing homes. We're going to have to really completely rethink in Georgia and across the country, but also in Georgia, 45% of all deaths from COVID have taken place in nursing homes. This should be the #1 story in the media every single day, because nursing homes and long-term care facilities only house 0.6% of the US population, yet 45% of the deaths nationally and in Georgia have been in long-term care facilities. And yet we haven't seen a lot of attention paid to that because at least the media wants to make it seem like everyone is at equal risk of dying of COVID, but that's not actually true. And that leads to the third point, which is, this is less of a problem in Georgia, but it certainly makes a big difference being able to reopen schools. Obviously, you can't reopen schools unless you have convincing data around infectivity among young people. And we have that kind of experience from Europe, but we needed more of that data here. And ultimately, I think the broader theme, particularly for state policymakers, is you've got to have ideally a system of decentralized information where, say, individuals have lab testing equipment or small home testing kits in their own homes that are allowed by state regulators and federal regulators that can report data to state public health officials where appropriate, or to their providers and their doctors where appropriate. And in that way, you can have a lot more real-time information. So information is a huge part of where there's been a lot of problems right now.
Yeah, Avik, you're absolutely right. And you've done a lot of thinking. Share with everybody the name of the report that people can take a look at that you've done if they want to dig a little bit more into how to think about the pandemic and reopening.
If you go to freop.org, that's freopp.org, which is our website, and then at the top you'll see a tab called COVID-19. If you just click on that, you'll see all of our work on policy reforms in COVID. And the main paper that details the laundry list that I was alluding to is called A New Strategy for Reopening the Economy During COVID-19.
Yeah, and I just want to underscore that everything Avik was saying about data, the Heritage Foundation will have a paper coming out in the next week or so. It's been, the CDC has ignored 4 laws passed by Congress over the last 14 years, telling them to fix their data problems and modernize it and have it be something that people can use. And most importantly, not just data that flows upward to policymakers, but goes back down to everybody. It's not just does the feds have the right information, it's does the state and local decision maker have the ability to have the data they need to make targeted decisions about where to impose public health interventions. And then even more importantly, do the doctors and the nurses and the people treating patients have access to that information? So the feds, our paper will focus on what the federal government needs to do, but we also know that the feds need to come alongside and better support state leaders in what they're doing. And I think this is a real opportunity where state leaders can step up and they're going to be able to gather the information they need more quickly and be able to equip the people in their state. CDC needs to come alongside and support that and catch up. But we've seen that some states have really good have better data, and others could do more as well. So if you're looking for a list, I know Avik has a list of the data points. We have a list of the data points. But the point is right now, the why you need it is that there's an inability to make, in many states, very targeted decisions about where to surge a public health measure, where to surge resources. And that's really led to, in some states, choosing these broad-based, and in my view, counterproductive lockdowns in many cases. So I think Avik and I would agree, data, key opportunity. But that leads us to another.
If I could just add,
yeah, absolutely.
quickly, one thing just to leverage on top of that is, with the nursing homes, a big part of the problem is that nursing homes are disproportionately Medicaid driven, and we all know about the inflexibility of Medicaid. And the more we can actually reform the Medicaid program so that people can get the care they need at home instead of having to live in what they call a congregate facility, the more you can reduce the risk of pandemics in long-term care facilities.
So a lesson for near term, and a lesson that would really help people longer term too, beyond a pandemic and a crisis. So thank you for that, Avik. And that gets us, I guess, to the next great question, which is, we've seen a lot of shifting really quickly around telehealth, which does let people, people of all ages get care from their own homes or on the go in a bus if that's where you want to do it, but lets you see your medical provider. And we've been seeing so many types of medicine being that people I don't think had quite conceived of before. Physical therapy, for example, has been approved for telehealth use by the feds when they look at Medicare policy. So we saw, policymakers at the federal government, policymakers at states sweep away barriers that had been getting in the way of telehealth use, which had been up and had been held back by regulatory barriers. So talk to us a little bit about what you're seeing and how policymakers should think about adapting the lessons that we've learned in this pandemic to apply those lessons for future path forward.
Yeah, I'll give 2 cheers to telehealth as we're seeing it play out in Washington and state capitals. And let me explain why I say that. The encouraging news is that telehealth has become bipartisan. We used to think of it years ago as just kind of a quirky free marketeer issue, but there's clearly a bipartisan interest in telehealth, and it is taking off all over the country because people are seeing the need and don't see it as particularly ideological, which is great. The warning sign, though, and the thing I would want to caution particularly Georgians about, is you're seeing an effort by lobbyists for healthcare special interests to say, well, we're for telehealth, but only if you pay us what you would pay for an in-person visit, make that exactly the same. And the problem with that is, if you actually import the government price schedule into telehealth, you eliminate all the opportunity for innovation. Because what you want to, ideally, part of the advantage of telehealth, part of it is if you live in a rural area, it just gives you access to healthcare full stop. But part of the advantage is you can do a lot of interventions less expensively than it would otherwise require to go to an actual physical doctor's office or hospital. So we want to create some price signal in telehealth and make sure that there's an opportunity for innovators to drive down the cost of telehealth and not merely incorporate it into the existing price-controlled system if we can avoid it.
Yeah, just to follow up on that point there, with the pricing models, there's one state that's done some pretty interesting work with how to think about payment that doesn't really fall into one bucket or the other. The good thing about paying people the exact same amount that they would get for an in-person visit as they would get for a telehealth visit is that you can kind of spur adoption really quickly. So we can see that making a lot of sense in a pandemic where doctors were being asked to stand up, telehealth practices in 48 hours a week. But as we think about where we want to go next, one of the things that Utah has been doing for a while that they reinforced as part of the pandemic is this notion of flexibility. So letting insurance companies or providers negotiate for what's fair. So it kind of sidesteps this box that some people have tried to suggest exists with saying, we're not gonna mandate the rate. We're gonna ask you all to figure it out. We are going to encourage you to cover it, but how you get there is up to you. And Georgia's also been a leader in another important part of telehealth, which is defining what that is. There is a push by some, Avik mentioned the lobbyists. I think everybody wants to make sure their own little slice of of healthcare is covered, and that's good. But what Georgia took, the path that they took, and that we're recommending others follow at Heritage, is that they really emphasized putting that decision about what kind of telehealth makes sense in the hands of a doctor and a patient. So that's where I think if, you know, there is a bipartisan consensus to make some of the regulatory relief that was done as part of the pandemic permanent. If you're looking beyond Georgia, you're looking to other states, people are going to want to look to Georgia's model for how to make sure that the way they define telehealth is one that allows for continued growth and innovation. So
one way to achieve both of those
yeah.
goals is to have a sunset. So you can spur adoption in the short term by having, say, a 2 or 3 year period in which the remote or telemedicine rates are linked to, you know, whatever you want to use as a benchmark, and then sunset it. So then at that point, you have, excuse me, I'm getting a call here. If you have the ability to then have the privately negotiated rates after that. And that's one way to kind of split the baby.
Yeah, many tactics, I think, for people to consider as we're trying to figure out how to take what was good and move it forward. So let's ask our other panelists to provide some wisdom to us. Brian, you have spent a lot of time thinking about how to make markets work better for patients and doctors and be more competitive. And one thing you've thought is really important is price transparency. Could you tell us what you found about this? Why is it important? How can we do it in a way that works for people without causing more problems? Brian?
Sure, thanks, Marie. And first, I should thank Avik. The work that he has done on the coronavirus is really, I mean, I think it's the top work that anyone's done in the entire country of really understanding the trade-offs involved and digging into the issues. So Avik and his team at FreeOp deserve a lot of credit for the work that they've done over the past 6 months, really to provide common sense recommendations, and hopefully schools will start to reopen sooner rather than later, which I say has, with having 3 kids who I will be homeschooling in a few weeks, it'd be great to get them back into school as soon as possible. On price transparency, the benefits of shopping accrue when on products where people spend a large part of their income and there's widespread price variation. And that's what we have in healthcare. In healthcare, about 20% of our incomes are expended on healthcare, and there are huge variations across providers. We know that consumers who are incentivized to shop, those who are spending before their deductible, are aware of price information, that they save money when they shop. I really dug into this issue about a year ago and thought deeply and looked at the research on the benefits of price transparency. I think many of them will accrue to employers in how they design their plans. One, it'll help employers monitor the insurers and the third-party administrators that they've hired to act on their behalf. I think one of the things that has become clear to me over the past few years is that the incentives that insurers have are not necessarily aligned with the incentives that employers have. Employers want the lowest possible care, lowest possible costs for quality care. Insurers are often make more profits the higher healthcare spending is. So over time, insurers seem to be going along with high hospital prices. And I think they sort of play this discount game with employers, where the hospitals and other providers set really large charge master prices. The insurer then says, we're getting you a discount off of this really outrageous charge master price. And the insurer can go to the employer and say, look at how much we saved you. And I think price transparency is going to help put a stop to that sort of shell game that's going on. I also think that price transparency is going to help employers design benefit structures that will incentivize employees to seek high value care. So one of them that I'm particularly enamored with and I think has real potential to lower costs is reference-based pricing. Under reference pricing models, employers or the payer set an amount for a service or procedure, and regardless of where the patient goes, that's the amount that the plan pays to the provider. What reference pricing does is provide information and an incentive. And where we've seen it, and we've seen private sector companies like Safeway successfully implement reference pricing, and also the California Public Employee and Retirement System that did reference pricing for orthopedic procedures. They set a reference price, and what you saw sort of immediately was a lot of people who weren't shopping started to shop. That's not surprising. What happened next might be more surprising. The high-priced facilities dramatically lowered their prices because people were now incentivized to find the best value. The average prices came down about 20%. There were significant savings to consumers. And maybe the neatest finding is that benefits accrued to people outside the reference pricing model. So just by having a few additional, relatively few additional shoppers, the high-priced providers had to lower their prices for everyone. So a paper came out last year that found that 75% of the benefit from those lower prices accrued to people outside the reference pricing model. One more point. I think employers are clearly going to need help from entrepreneurs and innovators to make sense of all the price information. The Trump administration has finalized a rule that was upheld by a district court judge that would require hospitals to post their price information. They are sort of going through the rulemaking process and preparing to finalize a rule that will require insurance companies to post their price information. It's going to be a flood of price information. And I think you'll see entrepreneurs and innovators sort that price information out and help employers and consumers find the best deal. And some of those deals will be outside of local regions. And you'll see cases where people are incentivized to travel to other regions. They'll be able to be housed, probably bring a loved one with them, and get care at a cheaper deal, at a cheaper rate at these so-called centers of excellence, which will put pressure on local providers to lower their prices. So I think the price transparency is going to have a broader effect of increasing competition as
So
well.
some people say that if you do price transparency, price will go up, but you were citing some studies that showed real life examples of where the opposite happened. Do you think those studies were a fluke, or why do you think they're representative of the larger whole?
Yeah, I mean, so this is something that when I was in the White House, we had some conversations about because there were some economists that thought in sort of how weird the healthcare markets are with the role of insurance companies. The price information could enable greater collusion in the markets and lead to the lower price facilities raising their prices and having an upward pressure on prices. You know, I talked to a lot of other economists who really cast a lot of doubt on this. They think that the hospitals and providers sort of already know what each other's relative prices are. And really, this is going to lead to competition and greater information. And I think one of the main reasons we should think the price transparency will lower prices is because of who the opponents to price transparency are. The opponents of price transparency are the entities that benefit from higher prices. If they thought the prices were going to go up and they were going to be better off, why would they be fighting efforts to enact greater price transparency so hard?
Well, that is a good question worth digging into a bit after this, I think. Avik, did you have anything you wanted to add to this? I know you've looked at the question as well.
Well, first of all, thanks, Brian, for the kind words, and I agree with everything Brian said. I would add that there's actually a set of regulations that new regulations or regulatory reforms that the Trump administration has put into place that require hospitals to disclose their prices negotiated with insurers. That was recently upheld at, I think it was a federal district court, so it's still going to be appealed by the hospital lobby and others and the insurers who don't want to see these prices in the public domain. But it looks like those the opinion from the lower court was pretty compellingly written. And I think it should be upheld or even not even heard at the appellate level. So if that's true and that ruling is upheld in the courts, that is going to revolutionize the price transparency movement. And a big part of why is we heard from Chairman Hatchett about the all-payer claims database that Georgia is trying to pass in Georgia. That's a very important measure, and that'll do a lot to achieve some progress in the near term. But the problem with state-based all-payer claims databases is they can only apply to fully insured plans. That is, employers who hire an insurance company and the insurance company is taking the financial risk. For so-called self-insured companies that use the ERISA law to basically be exempt from state regulations, the all-payer claims database doesn't affect them. So a Coca-Cola or a Delta Airlines in Georgia would not be basically affected by the all-payer claims database law, and that involves a lot of workers who are based in who work for those big companies. So a national system, for better or for worse, is necessary in this domain, and we are on the verge of achieving that. And I think what's going to be really important for Georgians is to take advantage, keep an eye on those new rules as they evolve and go through the courts, and make sure that as soon as we have certainty around that, you're taking advantage of it to create both public databases and public-private partnerships that allow patients to get the best information and employers to get the best information as to where they can get the best prices for their workers.
So I guess then that leads to a follow-up question on a factual basis. You know, Brian, maybe since you worked on these rules, you mentioned reference pricing. Could you explain a little bit how CMS plays a role in all of this? You know, they have a certain price right now. It's not really a reference price. So do you anticipate the price transparency changes having much of an effect, particularly in Medicare? Or could you sort of walk us through maybe 30, 45 seconds about how you see that working together?
Yeah, I mean, so I see the benefit of reference pricing more for employer-sponsored coverage. In Medicaid, you have very limited co-payments that are allowed. So you can't really institute a reference pricing model, because the key with the reference pricing model is the incentive that when a person spends more than the reference price, that's money that is coming out of their pocket. I don't think you can institute reference pricing like that in Medicaid, because you can't waive the limited co-payments, or you'd have to do an 1115 waiver, and I think it would be more challenging. Where I think the states should do it all. California has shown the way on this. Montana, Marilyn will talk about what Montana did. Montana's done great reforms through their state employee program. But all states should implement reference pricing for their state public employees program. You've got tens of thousands of public employees throughout the state. And like California showed, when you have such a high number of employees, you can influence prices throughout the state healthcare system. Again, 75% of the benefit from the effect of the reference pricing from the lower prices in California accrued to people who weren't a part of the reference pricing structure. So again, Maria, I think the price transparency will help employers and those working with employers know where to set the reference-based price. And then you'll have individuals, I think entrepreneurs that help employees navigate the system and make the best use of the reference price structure.
So one of our largest blocks of, as a group of purchasers of healthcare would really benefit, and so too the people getting care from them. Okay, all right. Well, that actually is a great segue into a conversation, a question from Marilyn. You have really spent a lot of time digging into both competition, but then specifically how to leverage a state health benefit plan to drive competition. Share with us some of your experience so that we can learn how you're thinking about these questions and what policymakers might be considering as potential reforms. Marilyn?
Thank you, Marie, I sure will. And thank you, Brian. I have sure enjoyed being a beneficiary of your work on price transparency. And same with you, Avik. I have surely enjoyed everything on COVID. I just go to your sources, and I really thank you for all the work you're doing. I'm going to share my screen. I'm going to try to. Hopefully. Can you see it?
I can see it, Marilyn, yes.
Great. I'm going to talk just briefly. I think that state employee health plans are an area that really need need to be addressed. They can lead the way. In working with the National Academy of State Health Policy, I'm working with state employee health plans, and I think motivating them and moving them forward has been difficult. I came to the state of Montana plan late 2014. The plan was going bankrupt, and this is where I think government has a role. The state legislature basically passed a law that said the state health plan had to be turned around, or else drastic measures were being taken and employees were not getting pay raises. So what I did in 2.5 years, I converted all Montana hospitals to be paid as a multiple of Medicare. I looked at what we were paying, which goes back to what Avik talked about. You have to get the data. I couldn't get it from the carrier. I got it from the actuary. And I saw that we were paying up to 611% of Medicare at some of the facilities. I put in a transparent pass-through pharmacy, no spread, a waste-free formulary, employer group waiver plan for retirees. I also created a medication therapy management program using the independent pharmacists, 113 in Montana, and our pharmacy school are reaching out to our members to help them. Primary care is big. We steered them to on-site health centers. I got rid of duplicate service. You're going to find this in state health plans. They tend to stack vendors. I terminated contracts because I didn't like them. I didn't like the hidden clauses that were in there with the TPA, the lack of transparency, the PBM, the consultant contract. I renegotiated and amended vendor contracts. And then I streamlined administration because I needed my data. I got off of the big state system and went with a cloud-based enrollment and a cloud-based data warehouse. And I did this in 2.5 years. And it is what I think state employee health plans need to be doing. So what happened? The red line shows what the actuary projected and presented to the legislature in Montana in January of 2015. Instead of minus 9 million in reserves, we ended up with 112 million. And employees were able to receive pay raises then in 2017 and 2019. Now, what I didn't expect was we were going to have more in reserves than the Montana General Fund. But that was okay, because all of the money goes into healthcare from taxpayers, employers, employees, and patients. It does not go into the system from the middlemen of insurance companies and PBMs. It goes into the system from all of us. So they passed a law to take 25 million of our reserves back to the general fund, which was a good thing. Our plan reserves are still doing very well. They're double the recommended level, and even bigger, our OPEB liability was significantly reduced. So this is just a little slide that I shared with, because I got a lot of opposition, clear from AHIP, from insurance companies. They were the worst, at the Hospital Association, but it was up to the Montana legislators to decide what they wanted to do. What could they do for 25 million that I could take out of the system and get back to them? They could retain jobs, build rural roads, support Medicaid enrollees, or educate over 2,000 in public schools. So that's my spiel. And I think that that is something that an area, and I'm really glad Brian mentioned it, state employee health plans are usually the largest health plan, usually the largest self-funded plan in the state. And I think as a fiduciary over that plan, you have the requirement to make sure every penny is appropriately spent. And if you can't follow the money, then you find a vendor who can work with you. Now, there are things with competition where I think I'm seeing some legislation be helpful in these contracts between hospitals and insurance companies. One is getting rid of most favored nation clauses. That's where the provider payment has to be at least as favorable as any other provider. There's been gag clauses, not allowing some transparency tools to evolve. I was able to use Healthcare Blue Book, where I was able to show quality and price to the members, but I had to make sure my contract allowed for it. There are several other things that can be done to from a legislature. But I'm going to stop on my story and go back to you, Marie.
Thank you for your story. I do want to pull the thread a little bit more. You mentioned competition several times. And maybe if you want to take this first, let me know. If not, we can ask one of our other panelists to do so. But we have seen, a decades-long trend towards consolidation, particularly in hospitals. And this has a direct impact on patients' ability to access care, and in many cases, the ability of the price for care. So, could you talk a bit more about how you approach this question? Does it matter? Should we be worried about it? If so, what are the tools that you look at and you would recommend people look at to begin to address it?
Yeah, I think it's a very, very big problem. And we're talking about horizontal and vertical consolidation. I think what we have really seen, I have worked more in Montana on vertical integration, and that is hospitals buying up physician practices. And we can see now for the first time in 2018, there were more physicians employed by hospitals than were employed independently. And we've been dealing with those issues. First, you see facility fees come in. You see that the hospital tax on, and for any outpatient setting or a doctor's office, they'll tack on a facility fee. NASHB has just come forth with draft model legislation and a white paper written by Aaron Fusti Brown out of Georgia, and that is on our website. I think I am most concerned because you see the prices go up. You also see more referrals going into the hospitals at higher prices and specialists. These higher prices, you can read report after report, they're not supported by higher quality or efficiency. And one of my pet peeves is 340B. The minute these doctors are purchased by hospitals and they write a script for a 340B eligible drug, then the hospital gets to play a part in that without ever seeing the drug. For instance, a hospital can buy Humira for a penny, and yet the plan is paying $5,000 for it. That profit shifted from the drug manufacturer to the hospital with no transparency whatsoever. So most of my recent work has been focused more on vertical integration, and we will be posting a site for NASHB that you'll be able to get those papers. It is very serious. I think it's an area for regulators. It's an area for antitrust, anti-competitive actions with laws in these contracts that can go in. And as much as I struggled with trying to get FTC help with the not-for-profit hospital behaviors here in Montana, that wasn't successful, as they don't have the regulatory authority. But I found out that they did have regulatory authority over hospital associations. So there are a lot of things that can be done and need to, but at the Georgia level, I would have them work with their attorney general and look at for different laws or contract law that can be used, and with the insurance commissioner's office for what can be presented for rate review.
Got it. And would you say, could you share a little bit, do you think that the reforms made in a state health plan could have pro-competition, pro all the good things we've been talking about, consequences beyond the state system itself? And if so, you're nodding your head. So share with us a bit why you think that.
The minute we brought in a private transparent pass-through, and we brought in this homemade version of competition within the MTM to compete against CVS and Walgreens, we saw a large consortium. The Montana Association of Healthcare Purchasers looked at this, but the Montana Association of Counties, the Montana Association of Cities followed path, pushed until they found a vendor that would support them. In many ways, they have better agreements than the state does now. We also saw private employers, the self-insured groups, start to push their brokers and start to push their people for the same things. The company that we did hire for our PBM now has a big footprint in Montana.
Okay. So significant consequences downstream, if you will, from the choices
really
you were making.
Mm-hmm.
Maybe in some states an under-leveraged resource that policymakers could
I think it's an under-leveraged. I think it's an under-leveraged resource, and I think legislators really should be looking at it. At NASHB right now, I'm preparing a short one-pager to be given to any legislator or budget director to say, these are things you could do immediately with your state health plan to save millions. Okay. And I think I think it needs to be done.
Okay. Well, when that is ready, I'm sure let's get that to Kyle.
I will get it to him.
Okay, great. Brian, you literally wrote the report for President Trump on how to promote competition. And you also did a lot to expand different kinds of coverage options, because choice in coverage is important to promoting competition. Could you talk us through a bit of what you did and why it matters and why policymakers should be paying attention to it?
Sure. You give me a little bit too much credit. I didn't write the entire report. The report you're referring to is titled Reforming America's Healthcare System Through Choice and Competition. It's a 120-page report that the Trump administration put out in December of 2018. When people say the Trump administration doesn't have a healthcare plan, I point out that we put out a 120-page healthcare plan that has a comprehensive list of recommendations for policymakers at the federal and state level, and is really motivated by a quote from Regina Hertzlinger, who's a professor at the Harvard Business School. And her quote is, "Choice supports competition, competition fuels innovation, and innovation is the only way to make things better and cheaper." So it really does, it starts with choice and properly aligned incentives. So part of that is that consumers need to have different ways to finance their health care. Obviously, I think the better incentives are when people are spending their own money. So I'm a big fan of health savings accounts. And I think one of the most important federal reforms would be to increase the number of insurance plans that can be integrated with health savings accounts. Obviously, that is a federal issue. We did open up options for individuals. This is in the aftermath of the failure to modify the Affordable Care Act, where we ended up doing three specific things. We expanded association health plans. These are ways that small businesses can join together to offer coverage, get some economies of scale and regulatory advantages. We expanded things called short-term limited duration insurance, which really is a free market for health insurance, where there are no federal regulations beyond sort of a disclosure requirement. We reversed Obama administration rules to allow people to maintain these policies for up to 364 days and renew them for up to 3 years. Chris Pope actually did a really fabulous study of short-term plans, and he used Georgia as his case study, and he found that people for equivalent insurance protection could get savings from short-term plans from 50 to 70%. The last thing I will mention here could be the most profound. Avik did a great op-ed on it back in June 2019. It's on an expansion of health reimbursement arrangements. So these are ways, I mean, one of the main problems with healthcare is that so many people come between the consumer and the provider. It includes the government bureaucracy that sets prices and determines what's going to be covered. The problem with the bureaucracy is that it is almost inherently inefficient and not innovative, and is subject to lobbying forces. So it's very hard to change the bureaucracy. You really need people like Marilyn Bartlett, who are just dedicated and are going to fight tooth and nail to move the bureaucracy. But we also outsource a lot of our decisions to employers, and employers select our health insurance. What other major financial purchases do employers select for us? What we did was finalize a rule that instead of the employer selecting the plan, allows the employer to provide tax-free contributions to employees that employees can then use to pick a plan in the individual market that works best for them. Really a way to maximize choice, and then plans will figure out what consumers value, and ideally you would get more competition and innovation through that mechanism.
Thank you, Brian. So we have quite a list of questions from the audience, and I want to be able to go through those. So what I'd like to do is I'm going to ask the question. I'll call on a panelist, but if you all think that you want to contribute, just jump in and we'll make it work. So maybe spend 45 seconds, Brian. What has the virus, you know, the pandemic and the response to it, highlighted that things that need to be reformed in our healthcare system. For example, we know that there's been certain burdensome rules that have been eliminated to get to better outcomes. What other rules might we target that would to eliminate that wouldn't compromise safety? And I know this has sort of been a theme throughout this conversation today, but maybe hone in on that for the person asking the question.
Well, I would say two. One is all the restrictions on healthcare supply. So like, I think we saw sort of the stupidity of certificate of need laws, from restrictions on telehealth, restrictions on scope of practice that prevented nurses from really, and nurse practitioners from doing what nurses can do to care for patients. So states issued sort of a lot of governors issued emergency declarations to loosen all of those for a period of time during the pandemic. Those restrictions never made sense, and are really just put in there by incumbent firms to reduce the competition that they face. I would say another issue is like the problems with employer-sponsored insurance. If people lose their jobs, and insurance is tied to their jobs, they lose their health insurance. I think that's one of the reasons why I think there should be more sort of support for the mechanisms where employers provide defined contributions, or the tax benefit isn't tied to the employer plan, but there's equal tax benefit across the types of coverage people purchase.
Okay, thank you. Avik, do you want to jump in here? I'm confident you do.
Well, I mean, first of all, I really missed an opportunity earlier to give the shout outs to Brian and Marilyn, who have both done incredible work on health reform in the last 4 years. Brian was too modest in not taking enough credit for all the good things the Trump administration has done while he was there. He's been a real key player in all that, and very diligent about working through the system, which can be very hard. So full credit to Brian and Marilyn. Marilyn is a hero of mine, and I think to many people in the state reform world, because the way she was able to reform the state employee health plan in Montana and take on some really powerful interests to do so at a lower cost for state employees and for taxpayers was an incredible, remarkable job that other people have tried to do in other states and have failed. So if Georgians want to do what Marilyn did in Montana, hire Marilyn, because I think that may be the only way you get it done. Maybe I'll just stop there. I'm happy to add on the other topics, but.
So one job reference for Marilyn.
Thank you.
What about you? Is there anything, Marilyn, you would identify like kind of crisply for us what might be another regulation or more that could be repealed or removed without compromising safety?
Oh, I think there are so many. Definitely. I mean, Brian has really gone down the list of this, and I was fortunate to be able to work a little bit on the Lower Healthcare Cost Act with Senator Alexander, and a little bit behind the scenes on some things Brian was working on. I think it all goes back to your original question of bringing transparency into all of this, understanding those contracts, understanding what's in it, looking at a PBM contract that says we PBM have the right to substitute any brand drug that's not on your formulary, and we keep 100% of the rebate. People sign those things. It's bringing some good sound ethics and maybe some legal requirements into the contracting, and quit pushing the little people out, the innovators, the people that are coming along that maybe can't meet the GPO pricing of a hospital, and opening up the market.
And what would you say, you know, some of these, you mentioned, I don't want to use the word little people but yeah, and let's call them innovators. Let's call them the upstarts, the innovators, the people who this system generally isn't designed for. What, you know, some of these things might be, you know, these innovative emerging models like direct primary care or a cash only model, you know, if you don't want to use direct primary care as a term, but like the concept behind it is the doctor, I mean, you're familiar with this, but the doctor and the patient work together largely through a cash model to deliver care. And there's other, you know, other ideas like charitable clinics. How do you sort of see ways, their role in larger reforms and ways to empower them?
Oh, they're definitely the key in the bigger reform. We did the on-site health centers, which were basically no copay, tests done there were no charges, and access was never an issue. And 20-minute appointments direct with the member. I really like DPC. I like independent doctors even being networked through systems that they can remain independent but work in kind of a DPC environment. I think you're seeing in states strong, at least we have, strong resistance by the insurance companies because that kind of diffutes their provider network, resistance from hospitals to these models. So I think legislators can really pay attention. Within Montana, there was a big push to call DPC insurance, and our commissioner was able to write an authoritative letter that it was not insurance. It's kind of taking its time. You're going to see some legislation this session to really open more doors to DPC. And I think there is a role for legislators in that arena to be able to open those markets a bit more to those innovators.
You know, one thing I might, go ahead.
No, please.
Go ahead, Mary. I was just going to say, Maria, in an almost contrarian way, I might actually pitch to the audience here an area where Georgia could actually engage in more regulation, but in more regulation in a market-based way, and that's antitrust. States have a real ability to take on regional hospital monopolies, which is a huge problem in every state, including Georgia. Of course, in Georgia, certificate of need laws are part of the problem with hospital monopolies, so you got to tackle that. But on top of that, there is a role for antitrust at the state level to take on anti-competitive practices that regional hospital monopolies use. We've seen an example of this, for example, in California, where in Northern California, Sutter Health is the dominant player, and the California Attorney General sued to say, hey, you're doing a lot of anti-competitive things to force employers to basically overpay for your services because you're a monopoly, to force insurers and employers not to use lower cost alternatives if they're out there. And so that's something that the state can investigate, and Georgia can do that. So if Georgia should do more, as every state should, to surveil economic practices and anti-competitive practices by large hospital systems.
Well, that actually goes directly to another question we got from the audience saying, you know, we've talked about hospital consolidation and its role so far. Do you anticipate an acceleration of hospital or health system mergers? And if so, I don't want to prejudge your answer, but and if so, will this be positive or negative for the consumer?
I mean, I'm very concerned about it. We already see, in particular, rural hospitals rural hospitals have been declining in general, partly because they're not managed well, partly because of demographic changes, partly in terms of people moving to more metropolitan areas, partly because of advances in medical technology. The average length of stay for, say, a heart attack is shorter than it used to be. You don't even have to go to the hospital to get your knee replaced. You can go to an outpatient clinic. So the hospitals, if they haven't downsized to adapt to all those changes and advances, they've got a large fixed cost base, and they're not bringing enough revenue in to countermand that. And so you're seeing a lot of rural hospitals struggle with that combination of stuff. Then you throw onto that COVID, where basically they weren't allowed to have patients for a lot of elective procedures. And that has hammered not just rural hospitals, but hospitals in general that are relatively smaller, that have poor balance sheets. And that makes them much more vulnerable to being sold out to a larger hospital system acquirer. So I am very worried that a combination of closures and acquisitions will lead to a lot more consolidation in the hospital space. And again, this is where there is a proper role for regulators to ensure that competition takes place. And if the state needs to do things to help support those rural hospitals and get them through this transition, you should consider that rather than just saying, you know what, the easy solution to keep this rural hospital going is to sell it to a larger player. Because that may seem like the easy solution now, but when that larger hospital system raises the price of everything by 15% next year, you won't think it's the easy solution.
One of the things here that the Federal Trade Commission is concerned about are these things called certificates of public advantage. So what they're seeing is that hospitals in states are getting the state legislature to pass these certificates of public advantage that basically immunize the merging hospitals from antitrust scrutiny. So states should there's no reason to pass these certificates of public advantage. On the certificate of need laws, the Mercatus Center has done really, really good work on certificate of need. They've gone through all of the explanations that people give for certificate of need and refute all of them. They definitively find the certificate of need raises costs, reduces supply, and harms outcomes. And they've done state-by-state estimates. So you can find, I went on this morning and said for Georgia, if Georgia got rid of its certificate of need laws, it would reduce total per capita healthcare spending by about $200. It would lead to far more hospitals opening in the state, and it would lead to a 5% reduction in deaths from post-surgery complications.
So Brian, I'm going to shift gears slightly here because we're gonna take advantage of your recent administration work. Georgia has 2 waivers pending with CMS, a 115 and a 1332. What do you think of these still pending waivers? You know, many people who have observed them think that they're pretty innovative and creative. Talk a little bit about your reaction, why things are still pending, and where people should go from here.
Well, I'm not familiar with what the 1115 Georgia waiver does. I looked at their 1332 waiver a while ago. I think the failure here, the CMS has been able to approve maybe about 10 state 1332 waivers, but all of them are to institute reinsurance programs. I'm not opposed to a state instituting a reinsurance program. I think it gets at how inefficiently designed the premium tax credits are in the ACA, and that money could be better spent in different ways. But reinsurance program is not particularly innovative. Allowing people to apply financial assistance to other types of plans, that is more innovative. That does open up choices. I think it's difficult to get through the 4 guardrails for 1332 waivers, one of which is budget neutrality. And the Trump administration put out sort of more flexible 1332 guidelines. What we should have done is put out model waivers for states so that states that were interested in them could check some boxes, have some actuarial and modeling work done, and get them in for approval. I think it's unfortunate that we didn't do more to help states along the lines. And you've got states like Georgia that have submitted waivers and are, I think, probably in a frustrated place right now because it is just taking forever, the process.
Yeah, I think the way people have described risk mitigation waivers is that it's table stakes. It's the thing that one does because one knows it lowers premiums. It's lowered premiums in every state that has it. But more needs to be done. Sort of the innovative things you were talking about, all the things we were talking about today to encourage competition. So it's one part of the puzzle. You know, then it kind of comes back to this question that was asked earlier: what regulations need to continue to be removed, drawing on our lessons from the pandemic. And I think the Trump administration's really pushed the envelope in terms, you know, through leaders like you, Brian, to remove a lot of the regulatory restrictions that were getting in the way of different kinds of care, innovative care, more competition, and their regulations. And so that's one reason it matters that Congress codify these things. They need to codify them, provide a stable footing going forward, and then move on and do more things in the spirit of the deregulations that the Trump administration has pursued. A good place to start would be more freedom for Georgia to pursue the innovations that they're trying to do in these waivers without having to do a mother may I every time they come to HHS and CMS. So
Marie,
yes, please jump in.
This is Matt Hatchett. It's funny you brought this up. I did ask the governors and the administration for an update on this early this morning, and
great timing.
They're very positive that both of these will be approved soon. definitely in time for the July 2021 implementation. And they have been back and forth on both of the applications. There's a very open discussion, and they're very positive that both of them will be approved. So just wanted to give you that update.
A well-timed update.
Details.
Well-timed update. Thank you for jumping in. We're getting to the end of our questions, and it looks like the one that's most pending is one that I think it's a good question, and the answer is not straightforward. So I'm going to take a crack at it. I'm going to ask Avik to take a crack at it. And the question is, how has HIPAA, which is the federal law that governs patient privacy in the collection of their information, hindered the dissemination of COVID information to both leaders and the general public? When you look at the information available to the public, and I'm just reading the question here, through the DPH website, there are real problems getting a clear picture of what this information means. There's a lack of information on the types of people testing positive for COVID on a day-by-day basis. So for example, people want to know, are the new questions mostly in young people with no chronic conditions? Or are they found in particularly vulnerable populations? And I think this kind of brings us back to where we started, which is the question about HIPAA is pretty long, and if you're really interested in all the details, there's a forthcoming Heritage paper probably in the next week or so by scholars Doug Badger and Joel White, who will answer that question in great detail. But that's not the problem as much as the policymakers aren't asking the right questions. The questions you posed are the ones that we need to know better information about. And there's a way to do this that protects patient privacy. But the problem is that these questions aren't consistently being asked and answered. So I was a little hesitant to get into this because I think it deserves a full answer. And I'm going to direct you to the paper for the fuller answer. Avik, you spent some time really thinking about data and kind of what aren't the right questions that should be asked and aren't being asked. I don't know if you want to jump in here to close this out.
Yeah, so we at FreeOp, we published a paper on this topic a year ago called Bringing the Digital Revolution to Healthcare, which is actually an updated version of a paper we published a few years before that. So we've been on this digital health revolution issue for a long time, and HIPAA is the major obstacle. The thing to remember, HIPAA was passed in 1996. It was basically Bill Clinton's what he called the Healthcare Bill of Rights. Some of you may remember, which after Hillary Care failed, that was his stab at health reform. And so HIPAA basically was passed barely, the internet as we know it barely existed when HIPAA was passed, and certainly was not designed to take into account the explosion of information technology, smartphones, everything else that came afterwards, along with the High-Tech Act of 2009-10, which also similarly is not really designed for the modern tech world. So we have a lot of laws on the books now that are constraining the ability of healthcare information to be used intelligently. And there's a lot to do to reform that. One thing I would point the audience to is the Trump administration, again, put out an unheralded but very important overhaul and modernization of the regulations that apply to what's called data liquidity, the ability of information to go with the patient's permission from one place to another and attract value. I'll give you an example, and it's not just by the way HIPAA, it's also anti-kickback laws and what's called the Stark Law. So there are these incredibly onerous federal criminal penalties. If you so much as charge $1 for helping a patient make sure that his records go to his primary care doc, his cardiologist, and the local hospital, if you so much as charge $1 for that, you could go to federal prison. So that's the nature of the uncertainty in federal law right now. And again, the Trump administration has tried to create some clarity around that, but there absolutely needs to be a re-examination from the ground up of these laws. And the problem is you're not seeing it, because the big tech companies that have the resources to navigate these regulations are fine with them, because they have trillions of dollars in market cap, billions of dollars in lawyers, and they can navigate anything they need to. It's the entrepreneurs and the startups that don't have those resources. So if we want real innovation in this system, we need to do a lot more to modernize and update those laws while still protecting patient privacy, because that's important.
I would say that's absolutely true for going forward, future reforms. Using the emergency authorities, HIPAA has not been an issue with expanding telehealth. The administration's done a good job putting out some pretty specific guidance, giving clarity there. but we're going to need to come back and look at that and make sure that that's an approach we want to use going forward. With respect to the collection and use of public health data, there are laws in place that govern that collection beyond HIPAA. And I think the problem continues to remain that we're not asking the right questions and that we're not using the information in the right way. Marilyn, are you jumping in because you want to answer the question, or are you? Oh, okay.
I'm taking notes madly. Thank you.
So I would separate the issues out from what Avik's talking about and the immediate need with respect to the better collection of public health data. Like, is a person who has tested positive, does that record for that person, is that person young, is that person in a nursing home? And the data is not consistent across the states, and it's certainly not being leveraged well or collected at the federal level in a meaningful way. With that, we are at our time, a little over it. So I'm going to give this back to Kyle to close us out.
Thank you so much, Marie. And thanks to all of our panelists, Chairman Hatchett as well. Just a really informative and wide-ranging discussion, but really drilling down on some key areas where there are some opportunities for Georgia. And so we really appreciate each of you bringing your expertise to us and our audience this morning on such a timely topic. Before we conclude, I'd like to thank our sponsors one more time, our presenting sponsor, AT&T, our platinum sponsors, Verizon and the Walton Family Foundation, and our silver sponsor, the Georgia Association of Realtors. And please remember to join us on Thursday for our closing event of this series with Chief Justice Harold Melton of the Georgia Supreme Court. Until then, thank you for joining us this morning, and we're adjourned.